Good afternoon and welcome to this integrated seminar on viral infections as part of pharmacology teaching. And I believe you already had a lecture on antiviral drugs in the morning. So in this seminar, we'll discuss viral infections like influenza, COVID-19 and HIV. Uh, I'll discuss influenza and COVID-19, and Dr. Sanjeev Sinha, Professor of Medicine, will discuss about HIV. So let us see first influenza. There are three types of viruses, A, B and C, and divided into subgroups based on two proteins on the surface of the virus. And these are hemagglutinins, there are 16 subgroups, and neuraminidase, 9 subgroups. And then there are different types of influenza. It may be H1N1, it may be S2N3, H1N5, and so on. We need to understand the characteristic of influenza A virus. Influenza can swap or reassort genetic material and merge, and that is called antigenic shift. The antigenic shift leads to novel subtype different from parent viruses, and the population would not have immunity against the new subtype once there is a major shift in the material of influenza. And even if a person is protected against seasonal influenza, may not get protection if he or she gets an infection with this new virus which has been reassorted after an antigenic shift. And antigenic shift has historically led to highly lethal pandemic, and one of them is Spanish flu in 1918, which now we repeatedly discuss when we are going through a pandemic of COVID-19. So how this pandemic strain reassortment occurs in pigs? So say there are some migratory birds, water birds, they may go from one place to other and they may infect a local bird. They may infect the pigs, and a pig may get infection from a human also with a different strain of, or say, seasonal influenza. So what happens is that this pig may serve as a reassortment vessel, and there is a reassortment of these two viruses, genetic material of two viruses, and when it goes back in the human being, it may have a quality to transmit from human to human, and this will form this will make a outbreak of a viral infection. Specifically, it may be a say influenza virus. Say that's why it is called swine flu. When we had a major outbreak in 2009, a pandemic, some of you might have already heard of it. It was not to that extent as it is a pandemic of COVID. So what happens even in the human being, if human being gets a viral infection from the bird, and then another viral infection or another influenza in a human being, reassortment, and then it will cause a new virus that is called antigenic shift. And this was responsible for swine influenza or H1N1 pandemic in 2009. So what happens is transmission of infection occurs by infected pigs shed virus in their saliva, nasal secretions. Infection in men occurs by close contact with secretions of these infected pigs. Flu virus are spread mainly from person to person through droplet created while coughing or sneezing by a person infected with the influenza. So that's why, that is the reason why even now in COVID infection, as we will be discussing in next few slides, it is similar nature of infection, droplet infection, and that's why there is a role of distancing or 6 feet distance from a person who is having this infection. Incubation period in a seasonal influenza is 1 to 4 days. So it happens on the same day or up to 4 days. In swine influenza epidemic in 2009, it was 2 to 4 days. However, upper limit was as high as 8 to 17 days. In 1997, an outbreak, it was 3 days. In 2004, 6 days. And in 2005, 6 days, suggesting that there may be a minor variation in the incubation period. The common clinical symptoms of influenza include, they are similar to any other respiratory pathogen like cold, fever, cough, sore throat, and in pediatric patients there may be loose stools and vomiting, and rarely it may affect the brain, causing encephalopathy. And in severe form, it may cause pneumonia and acute lung injury. Young children are less likely to have a typical influenza symptoms like fever, cold, cough, or sore throat. They may present with fever and lethargy without cough or other respiratory symptoms or signs. So how you identify them? Say some adult member in the family is having an influenza-like illness which consists of fever, cough, cold, sore throat, and then an infant in the same family presents with fever and lethargy, then you will consider that possibly he might had a influenza infection, and you investigate and treat it accordingly. Severe disease includes, in a smaller children, apnea means not breathing, tachypnea, rapid respiration, difficulty in breathing, and in severe form, there may be cyanosis, dehydration, altered mental status, and extreme irritability. Which are the groups which may develop a severe disease in seasonal influenza or even H1N1, that is a pandemic? So in that case, it was age below 5 years and above 65 years. So infants and young children and elderly, they are at risk of developing severe disease even when they get a seasonal influenza. Children and adolescents like less than 18 years on long-term aspirin therapy might be at risk of experiencing Reye syndrome after influenza virus infection. That is one of the severe form of disease complication. Pregnant ladies and adult children with chronic pulmonary, cardiovascular, hepatic, hematological, neurological, neuromuscular or metabolic disorders. Adults and children who are getting immunosuppressants like steroids for anything, primary or secondary immune deficiency, or cancer chemotherapy. Residents of nursing home and other chronic care facilities are at increased risk of getting infection and occasionally severe disease also. So how you make a diagnosis? You do a real-time PCR, RT-PCR on nasopharyngeal secretions or throat swab. Another one is viral culture. So it is, and the third one is fourfold rise in swine influenza specific neutralizing antibodies. But these two, viral culture and increase in the fourfold increase in the neutralizing antibodies, are not being used for making a diagnosis. We are dependent on RT-PCR. And there is a confirmation of diagnosis may not be required in all cases. PCR is required only in a smaller proportion where you want to know what is the strain of this influenza and whether there is a need for specific treatment or if there is a severe disease. Principles of treatment of influenza infection, specifically H1N1, is assess severity, decide about whether patient can be treated on ambulatory basis or hospitalization. So this is based on, you check the respiratory rate, heart rate, blood pressure, look for respiratory difficulty, look for hypoxia, and whether, if it is a small child, whether the child is able to take orally or feeding well. And then you explain if then you follow the isolation and observation universally precaution, good infection control practices, and use antiviral drugs. So if a patient has a stable vitals, meaning thereby normal heart rate, normal respiratory rate, no respiratory difficulty, a small child who is feeding well and not having a chest syndrome, not hypoxic as indicated by oxygen saturation of more than 94% in room air, they could be treated at home after taking nasopharyngeal swab and advised to do self-monitoring at home, or if it is a child, then it is done by parents. Treatment required is paracetamol or ibuprofen for fever and myalgia and headache, and encourage child and adult patient to take plenty of liquids to avoid dehydration. If child is sick as indicated by unstable vital parameters, low blood pressure, hypoxia, high heart rate, respiratory rate, child is, if it is a child patient, then poor intake, and if there is a respiratory difficulty and hypotensive shock, severe dyspnea like a acute respiratory distress syndrome, these patients require hospitalization and admission in intensive care unit. Apart from symptomatic treatment, which would be similar to that of any other patient who is having acute respiratory distress syndrome, you give the treatment, a treatment similar to that of a shock for all the patients, including child or adults. In addition, you will administer antiviral drugs. And antiviral drugs, what are the drugs which are effective against influenza? One is amantadine and ramantadine, which are effective against influenza A, but they are not effective against H1N1 virus. Neuraminidase inhibitor, that include oseltamivir and zanamivir. Zanamivir is administered as an aerosol. That's why it is not easily available, and that's why it is not being used routinely. Oseltamivir is the only orally effective drug which is being used, widespread use in H1N1 viral infection. For adults, it is 75 milligram twice a day, but in children, it depends on the weight of the child. Less than 15 kilo, 30 milligram twice a day. 15 to 23 kilogram, 45 milligram twice a day. 23 to 40 kilogram, 60 milligram twice a day. And if it is more than 40 kilogram, then it would be similar to that of an adult, 75 milligram twice a day. And it is to be given for 5 days. And when to discharge? Once the child or adult patient admitted because of the moderate to severe or critical illness, then adult patients infection control precautions for 7 days after resolution of fever. So at least 7 days you will keep them in isolation in hospital. Children, they continue to shed virus, so infection control measures for 14 days after onset of illness. If due to some reason we are not able to keep the child in hospital for 14 days, in that case, child be allowed after discharge. I advise not to attend school, and parents should be educated to observe infection control measures at home. Otherwise, they will infect other children. Other children will take the infection home, and then their other household members may get infected. So that's why it is important that we explain them that how to use a control measures at home. So influenza can be prevented or controlled by vaccination, and there are two types of vaccination: live attenuated vaccine administered by a nasal spray, half of the dose in each nostril, and it can be used between 3 to 49 years of age. Below 3 years and above in the elderly, it is generally not recommended. And there is another one, inactivated, in which children 6 months through 9 years of age need 2 doses, and after that 1 dose, and it is to be administered every year. So now we come to an end of this infection due to influenza, and as you can see that we faced the pandemic of H1N1 in 2009. The treatment was supportive along with some antiviral drugs at that time, and we will see that how it is different from coronavirus infection, through which COVID pandemic we are passing through. So I'll discuss in brief about COVID-19 infection, how background, epidemiology, and diagnosis and management. So a new form of COVID viral infection due to SARS-CoV-2 was declared as a public health emergency and international concern on 30th January 2020 and subsequently declared it to be a pandemic on 11th March 2020. This was by WHO. Though infection started emerging in China in Wuhan in November-December 2019. The median incubation period for this virus is around 5 days, which may range between 2 to 14 days, majority between 5 to 7 days. As per current evidence, the period of infectivity starts 2 days prior to the onset of symptoms and lasts up to 8 days. India is passing through the second wave. India started having a outbreak in the March 2020, then it increased first wave, and now from last March and end of the March till now we are passing through the second wave of COVID. You can see here that data on a daily cases here, there was a dip and then there is an increase, and daily new cases in India, there was peak somewhere in August, September last year, and now there is another peak. Now that is receding from May on middle of the May onwards. You can see that different age groups are at a different risk as indicated by patients diagnosed in a particular age group. So you can see here that the children below 20 years of age, below 10 years, they constituted around 3% and above 10 years around 9% of the total infection due to COVID infection in our country. While majority of the patients belong to middle age group from 20 to 50 years, though the number of patients above 60 years were less, but case fatality was very high. Here, as compared to influenza, COVID-19 was less severe, less common as compared to influenza in children. While as you had seen, influenza was more severe, more common below 5 years of age. So, why children are less frequently or less severely affected? It is not known very clearly, but it's very clear that though children constitute around 40-45% below 20 years, 40-45% of the total population, but proportion of patients suffering from COVID infection was just 12%, and severity, case fatality was very less. So the hypothesis given is that expression of primary target receptor. You may be aware that the coronavirus COVID-19, it gets attached to a receptor, that is angiotensin converting enzyme to ACE2 inhibitors, and that is less in pediatric patients. Children have a strong innate immune response due to trained immunity secondary to live vaccines and frequent viral infection, and that may help in early control of infection at the site of entry itself. Adult patients show suppressed adaptive immunity and dysfunctional overactive innate immune response in severe infection, which is not seen in children. Excellent regeneration capacity of pediatric alveolar epithelium may be contributing to early recovery and less severe COVID-19. Additionally, children are less frequently have a risk factor such as comorbidities like diabetes and smoking in children. So these are various hypotheses which have been suggested that why children are less severely affected, and though people feel that there may be a third wave and in that children may be more severely affected, but as we had seen even in the first wave and second wave, the proportion of children affected were same. So it is less likely that in third wave there will be suddenly increase in the number of children having this problem. People feel that those above 18 years of age, either in first or second wave, has got infected, so that's why they may have a protection due to natural infection, and many of them might have got vaccine. But this is also, and that's why the susceptible population will be children below 18 years of age. But it is not, it is clear that even sero surveillance have suggested that children between 12 to 18 years were infected, as evident by the presence of antibodies in their blood in the surveillance studies, but they got infection either asymptomatic or mildly symptomatic. So that's why it is not clear that why children should get affected more in the third wave. The diagnosis of COVID-19, again, it is by either by RT-PCR or CB-NAT, real-time PCR or from the throat swab, nasopharyngeal swab, and this is the gold standard as of now. And there is another test, because RT-PCR may take 4 to 6 hours for getting a result. There is another test which is a rapid antigen detection test. Samples are same. It has a specificity of more than 98%. Means if it is positive, it means chances of false positivity are minimal. But it has a low sensitivity of around 80%, suggesting that if I do a rapid antigen test on a symptomatic patient, I may be able to identify 80 out of 100, but I may miss 20. So in that case, if there is an outbreak going on, if I do it on a symptomatic person in an emergency room, I may be able to identify the infection within 15 minutes. So it is a point of care test. But if it is negative, in that case, I may have to confirm it by doing a RT-PCR that it is negative and person is not a COVID infection. Clinical phenotype of COVID-19 can be classified into these four classes. One is pre-symptomatic. This is time period between exposure to the virus and development of symptoms. So it may be that the person was exposed 5 days ago and now he is asymptomatic, and even 2 days before the presence of symptom, patient may be infectious. So during this time, patient may be infectious and it is before the symptoms are there. Pre-symptomatic is test is positive without any clinical symptoms and signs, and chest imaging is normal, and this is commonly seen in children, young infants, and even in adults. These people may be infectious though they are asymptomatic. Without knowing that they are infected with COVID-19, they may spread the disease. And classical manifestations are fever, cough, cold, sore throat, and shortness of breath, depending on severity that we will be seeing later on. This is indistinguishable from other respiratory illness, including influenza infection. And certain small proportion of patients, specifically children, may have atypical symptoms in form of a gastrointestinal, like vomiting, diarrhea, pain, abdomen, but that is 5 to 10% of the patients, and 2 to 3% may have a skin lesion. So these are very less in number, but it may be there. So how to manage? So first and foremost is that we decide about what is the severity of disease, whether it is a mild, moderate, or severe disease, and depending on that, we can take a decision whether the patient can be managed at home or require hospitalization in ICU or in ward of a COVID hospital. So mild disease clinical features include influenza-like illness, children as well as adult having a cold, cough, sore throat, fever, not having respiratory difficulty, neither chest indrawing, no rapid respiratory rate, and not hypoxic. You will measure the oxygen saturation in room air and it should be 94 or more. If it is a child, then less than 2 months and breathing more than 60 per breath per minute, then it is not a mild. So it should be less than 60 per minute. In 3 to 11 months, less than 50 per minute. 12 to 16 months of age, less than 40 per minute. And more than 5 years, less than 30 breaths per minute. If it is more, it suggests that child is having a rapid respiration and he should be treated like a moderate disease. In adults, generally it should be less than 24. Between 24 to 30, it is a borderline, and above 30, it suggests that it is moderate to severe disease. Some children may have no fever or have only GI symptoms such as nausea, vomiting, abdominal pain, and diarrhea. That would be 5 to 10%. Physical examination of these patients may show just a congestion of pharynx, no auscultatory abnormality. So a person who is having just cough, cold, fever, no respiratory difficulty, no hypoxia, no other issues, you will say that this is a mild disease. And they do not require any additional blood test or chest imaging once you have made a diagnosis of COVID-19 based on a RT-PCR or rapid diagnostic test. Treatment for such patient is home isolation after assessment of feasibility. So how you assess the feasibility? You check how many rooms they have, whether there is a separate room with a separate washroom, and whether there are any people who are elderly at risk of developing an infection and very high case fatality. And the other important thing is that there is someone to monitor. Adult patient may monitor self, but a child should be monitored by a attendant or parents. So if it is feasible that yes, there is adequate physical facility, less likely to disseminate the infection to the other family members, and there is a possibility of monitoring at home, you may decide to treat them at home. But we explain them how to monitor an individual with infection and when to contact a healthcare person or reach to a healthcare services when there is some deterioration. If home isolation not feasible because of say small home, overcrowding, some high risk person is at home, in that case there may be a possibility of keeping the person in a COVID care center. There are multiple COVID care center in various these locations where these patients can be managed. The treatment is symptomatic. You can give paracetamol 10 to 15 milligram per kilo per dose, repeat every 4 to 6 hourly. And in adults, it may be 500 to 750 milligram of paracetamol 4 to 6 hourly. Generally, we try to avoid non-steroidal anti-inflammatory drugs like ibuprofen or mefenamic acid, though there are no evidence against these as of now. Cough suppression doesn't have any role. Throat soothing agents like warm saline gargles in older children, adolescents, and adults, and honey, tulsi, ginger, all can be used as a soothing agent. Antibiotics are not indicated, they will not change the course of illness, so that's why they should not be used. These drugs which were being used from time to time, but now with over a period of time, we have come to learn that none of these drugs have any role in management of COVID-19, including hydroxychloroquine, ivermectin, antiviral agents like lopinavir, ritonavir, remdesivir, umifenovir, and there are certain drugs like immunomodulators like tocilizumab, interferon, or convalescent plasma infusion. None of these are indicated in a mild COVID-19 infection. So to summarize, a child or an adult presenting with sore throat, rhinorrhea, cough, no fast breathing, no hypoxia, home isolation, or care in a COVID care center. Treatment is supportive, rest, adequate hydration and feeding, paracetamol, and report if worsening of the danger signs. Now we go on to the moderate disease. Moderate disease as indicated by fast breathing of more than 60 per minute for less than 2 months, more than 50 per minute for 2 to 12 months, more than 40 per minute for less 1 to 5 years, and more than 30 for more than 5 years of age. Same thing is for adults. If there is more than 24, then it is a cause of concern, and more than 30, definitely it suggests that it is a moderate to severe disease. No signs and symptoms of severe illness, and oxygen saturation is more than 90 but less than 94%. It suggests that we are dealing with a moderate disease. And as I already said, we have already made a diagnosis by doing a throat swab or nasopharyngeal secretions. These patients should be admitted in a COVID dedicated healthcare center or district hospital or a medical college hospital where there is a separate COVID care health center. These patients may need some investigation, but there is no blanket statement that all moderate patients should undergo some investigations. If indicated, you can do a hematology, biochemistry, laboratory testing, electrocardiogram and chest imaging if there is a worsening of the clinical symptoms. But otherwise, they are not indicated in all. And the treatment is oxygen supplementation to maintain SpO2 of more than 94%, inhaled bronchodilator if there is a wheezing, and MDI with spacer is preferred over nebulization to reduce aerosolization. Empiric antibiotic therapy. Antibiotic therapy is not indicated unless there is a suspicion of bacterial infection. Empirical antibiotic therapy as per local antibiogram, if there is a surveillance data and it suggests that yes, for pneumococcus, for Haemophilus influenzae, these are the antibiotics which are sensitive, can be given. Systemic steroids may be given if there is a rapid deterioration or hypoxia. Again, in moderate disease, there is no established therapy for COVID-19, no evidence to benefit of giving following drugs to a moderately affected person, including chloroquine, ivermectin, antiviral drugs, including remdesivir, immunomodulators like tocilizumab, interferon, or convalescent plasma. How to monitor these patients? Clinical monitoring in form of a heart rate, respiratory rate, blood pressure, oxygen saturation. Specifically look for work of breathing and oxygen requirement. So if laboratory tests are indicated, not as I said, not indicated in all, but if a person with a moderate disease admitted and shows worsening of symptoms suggesting that he is going towards a severe disease, in that case we can do a CBC, platelet, absolute lymphocyte count, kidney and liver function test to document organ dysfunction, and we may do inflammatory markers in form of a C-reactive protein, D-dimer, ferritin if available. If a patient has increased work of breathing, hemodynamic instability, or increase in oxygen requirement, if any of these things are there, in that case, patient should be referred to a higher center. So, to summarize, if someone is having a pneumonia, hypoxia, mild, admit them in a COVID care facility, COVID specific hospital, monitor for progress, antipyretics, paracetamol, amoxicillin if suspicion of bacterial infection, and if oxygen saturation is less than 94%, start oxygen. Add steroids if very rapid progression. So now we come to severe disease as defined by severe pneumonia or acute respiratory distress syndrome. There may be evidence of sepsis, septic shock, or multi-organ dysfunction syndrome, or pneumonia with any of the following like cyanosis, oxygen saturation less than 90%, and increased respiratory effort. Specifically in children and infants, there is a grunting or severe retraction. Person is lethargic, there is a somnolence or seizure. Any of these things are there with a background diagnosis of COVID-19 infection. This is categorized as severe illness, and these patients require hospitalization in intensive care in a COVID hospital. And if it is a mild acute respiratory distress syndrome, you give high flow nasal oxygen or non-invasive ventilation. If it is a severe, then the patient will require a mechanical ventilation with a low tidal volume, high PEEP peak and expiratory pressure with a cuffed endotracheal tube. Fluid restriction is indicated along with sedation, and if poor response, may try prone ventilation and high frequency oscillatory ventilation. So this is the outline of the treatment of a person who is severely ill or critically sick. For shock, you give a crystalloid bolus 10 to 20 milliliter per kilo over 30 to 60 minutes. Fast if there is a hypotension, but At the same time, careful administration to avoid fluid overload if there is a myocardial dysfunction. Early ionotropic support in form of epinephrine or dobutamine infusion, and monitor for fluid overload because there is a myocardial dysfunction. So this is about the treatment of severe and critically ill patients infected with COVID infection. Mild may be treated at home with a supportive care or in COVID care facility. Moderate and severe and critical, they require hospitalization. Severe and critical require hospitalization in an intensive care, may need high flow nasal oxygen or mechanical ventilation along with that supportive care. As you can see, there is no role of any other thing except in a severe and critical condition, we may give steroids to decrease the cytokine storm. A little bit about multisystem inflammatory syndrome temporally related to SARS-CoV-2 infection in children. This is a new disease which is described in April 2020, and now it is reported throughout the world, including India, and it happens that the person or a child below 18 or 19 years of age presents with fever, cough, breathlessness, along with some other organ dysfunction, and you make a diagnosis of multisystem inflammatory syndrome, and it happens that either knowingly or unknowingly the child got infected 2 to 6 weeks before the presentation. So the criteria for diagnosis of this multisystem inflammatory syndrome in children is children and adolescents 0 to 19 years of age presenting with fever for more than 3 days and having two of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammatory sign like oral, hands or feet, hypotension or shock, features of myocardial dysfunction, pericarditis, valvulitis or coronary abnormalities including echocardiographic finding, elevated troponin or pro-BNP. Evidence of coagulopathy as indicated by PT, PTT and elevated D dimers, or acute gastrointestinal symptoms like diarrhea, vomiting or abdominal pain. As you can see here, there is not much importance given to the respiratory symptoms because majority of these patients may not present with respiratory symptoms. Some of them may have it, but major abnormality is gastrointestinal or cardiac problem, along with that skin and conjunctival problem. Along with that, out of these two, and then elevated marker of inflammation such as C-reactive protein, ESR and procalcitonin. ESR more than 40, C-reactive protein of more than 5 or procalcitonin is raised. And no other obvious microbial cause of inflammation including bacterial sepsis, staphylococcal sepsis or streptococcal shock syndrome. And evidence of COVID-19 infection, either there was a documented RT-PCR positive in past 6 to 8 weeks, or there is a contact with patient with the COVID-19, or we could document that yes, RT-PCR is negative, but the child is having antibodies against COVID-19 positive, suggesting that he got infected in past. So one is clinical features, laboratory markers, ruling out other causes which can explain these abnormality, and evidence of direct or indirect evidence of infection due to COVID-19. These patients, as I said, this is a new disease diagnosed in children and occurs after 2 to 6 weeks of COVID infection. They are non-infectious, so they require hospitalization in a non-COVID facility in a pediatric wards or pediatric intensive care. So one is there is shock or life-threatening disease. In that case, you will give methylprednisolone along with intravenous immunoglobulin and along with the antimicrobial, because we may or may not be able to rule out if a child is in a shock we cannot wait for ruling out other infections. In that case, we investigate simultaneously for various bacterial infection. In this season, dengue infection, malarial infection, and typhus infection. On the other side, if there is no immediate life-threatening problem, like a patient is stable, not very hypoxic, we rule out first tropical infections like malaria, typhoid fever, scrub typhus, and then if none of these are present, then we start with steroids, and if required, we can give IV IgG. So now we come to what are the vaccines for COVID-19. There are multiple approaches. One is inactivated like Covaxin, which is available in our country, and another one is Covishield, which is also available, which is a prepared vaccine. They were rolled out within a year of identification of the pathogen, and two vaccines are available in India. There are more than 100 vaccine candidates which are being tested for various age groups. Two doses are given at interval of 4 to 8 weeks. Initially, they were being given every 4 weeks, but now with our experience that yes, increasing the duration between the two doses may improve the efficacy. That's why now it is between 4 to 12 weeks you can get a two doses, and efficacy for most of the vaccines is more than 80%. In children, initially, as you are aware, vaccines were given to frontline workers, including doctors, nurses, ward boys, those who are working in hospital, those who are providing services in this pandemic, subsequent, and those who were above 60 years of age, or all those who were having a comorbidity. Subsequently, it was extended to all population above 18 years of age. For children, because its safety and efficacy needs to be documented, it will be that test will be carried out, some studies will be carried out, and once they are found to be safe and efficacious, then they will be given to the children. So this is all about COVID infection. If you have any question, you can put it in the chat box.
Hello, sir. Am I audible?
Yes, yes.
Like the dosing interval. So Covishield interval has been increased right now. Like it's 12 to
Yes,
16
yes.
weeks.
Covaxin, it remains still 4 to 6 weeks, while for Covishield,
Right.
it is between 8 to 12 weeks. And as I said,
No, sir.
as we know
I
more
think
and more about vaccine efficacy, we try to implement it in a practice also.
they've increased it to 12 to 16 weeks.
Yeah,
Not
as I
8
said,
to 12.
initially it was increased to 8 weeks, now 12 to 16 weeks.
Right, right.
Any other question? Okay, now Dr. Sanjeev Sinha from medicine will talk to you, discuss about this thing. I'll just.
Yeah, thank you, Professor Kabra. I'll take it. Thank you very much for
I'll
excellent
just stop sharing. Now it's fine. You can share. Okay.
Yes, sir.
नहीं
तिवारी साहब, मैं यहाँ से शेयर कर लूँ स्लाइड?
हाँ सर, मैं 1 मिनट शेयर आप करेंगे सर?
हाँ, मैं अपने से
मैं
कर
आपको
लूँ।
प्रेजेंटर बना रहा हूँ सर।
अच्छा,
देखो इसमें नाम देखो।
हाँ संजीव सर,
अभी तो देखा था मैंने।
नीचे आ जाओ, नीचे। हाँ ये है ना प्रोफेसर संजीव।
ठीक है, हाँ।
सिन्हा, तो ये प्रोफेसर संजीव सिन्हा।
सॉरी यार।
हाँ ये
हाँ
है ना।
हाँ सर, ठीक है सर। आप अपना वो करो, स्लाइड
हाँ
शेयर करो। ठीक है, एक मिनट, ठीक है, बोल दो ना, स्लाइड हो गए सर, रहने दो, कॉल करने की जरूरत है। स्लाइड खोल लो।
नहीं, अभी कमांड आया नहीं।
आपका सर स्क्रीन दिख रहा है, स्लाइड नहीं खोली आपने।
नहीं, स्क्रीन तो मेरे उससे चल नहीं रही है, मेरे माउस से। इट इज नॉट रिस्पॉन्डिंग। आज शेयरिंग।
हाँ हाँ, आवाज आ ही जाएंगे आप, जाएंगे। ये तो आधी स्लाइड नहीं खुली कह रहे हैं। हाँ, स्लाइड खोलो, बोलो ना सर, बोलो सर, आपकी स्क्रीन आ रही है, स्लाइड खोलो।
हाँ नहीं, मैं कर रहा हूँ आंटी।
ठीक है, ओके,
ठीक है,
Slide is visible, so just maximize it, sir.
यस सर, राइट सर,
now you can see the slide.
Yes, sir,
yes,
we
yes,
can
yes,
see, sir.
yes.
You can see the slide.
Yes, sir, we can see the slide, sir.
Is it okay? Is it full screen?
Yes sir, yes sir.
Okay.
हाँ,
Okay, thank you.
Okay, sir.
So, good afternoon to everyone. I am Dr. Sanjeev Sinha. I am professor of medicine,
sit down.
and I am going to speak on the HIV management and this kind of recent updates for what different type of treatment we are going to use nowadays. And so this is kind of outline I'm going to discuss. I'm not going to discuss in very detail because at your level you basically need overview of HIV management. So briefly, I will be going to tell you about diagnosis, how to diagnose a HIV patient, what are the different kind of investigation we have, and then I'll be telling you about the treatment part and when to start the treatment, what kind of treatment do we start, and how to contract the regimen, and then what are the newer strategies, and then we'll have prophylaxis treatment like prophylaxis for opportunistic infection and pre and post-sexual prophylaxis. And I will also discuss about the monitoring, like how to monitor about the failure of the antiretroviral therapy and how to do the drug resistant testing. And there is a future cure like vaccine and other new drugs. So, so what are the different kind of investigation we do? We do the antibody detection, we do antigen uh, detection, we do nucleic acid detection. So there are three kind of investigation we do for diagnosis of HIV. And you can see here we have like in NACO we are using third generation investigation. So I would like to tell you here that NACO is National AIDS Control Organization, and it is controlled by Ministry of Health and Family Welfare. So earlier there was different program for AIDS and TB. Now they have merged and there is a single program, and both are done by same organization now. So here you can see other methods like for testing of HIV is conventional as ELISA test. That is very important test in our country. We do HIV ELISA test. And then we have rapid tests like dot spot, lateral flow assay, home assay, and we have Western blot assay. So when ELISA test or rapid test are not uh, showing any positivity and you have high suspicion of HIV, then you can go for the smallpox. We also have serum saliva test and which is approved by FDA, but it still have to be approved by NACO in India. So coming to the antigen detection test, and we have 324 antigen detected by 10 to 14 days, and this is mostly we do in the child age group or pediatric age group. And then we have nucleic acid test and can be used easily within 2 weeks, and this is also approved by CDC. So there are three kind of investigation I would like to just give a brief idea. One is antibody, another is antigen, and nucleic acid. I hope you get more detailed idea about these investigation in microbiology. So coming to the different kind of regimen and when regarding the when to start antiretroviral therapy. So there are different organizations like Department of Health and Human Services in the US and the European AIDS Control Society and then the World Health Organization and National AIDS Control Organization. And they have given the guideline. And according to them, they have started like as for CD4 count, earlier days there was antiretroviral therapy to be started as for CD4 count. And I still remember when we started doing antiretroviral therapy, and we had the antiretroviral center in our department in AIIMS. Then we only used to give antiretroviral therapy patient who had CD4 count less than 200. And now we are giving, you can see here, NACO is giving antiretroviral therapy free of cost, even without measuring any CD4 count. The patient is having a HIV positive, now you can start antiretroviral therapy without doing CD4 count, and later on you can do CD4 count. So now there is a direction from Ministry of Health, Government of India, test and treat policy for HIV for everyone. Anybody who is tested HIV positive and found positive will get the antiretroviral therapy irrespective of CD4 count or any clinical stage. So this is a new guideline that was based on the WHO guideline 2016, and now NACO and Ministry of Health, Government of India is also following same guideline since May 2007. So coming to the classes of ART, so you can see here there are some very common classes like I would tell you here, you can see that there are entry inhibitors and reverse transcriptase inhibitors and then integrase inhibitors, and they have protease inhibitors. So there are different kinds of antiretroviral therapy. When we started about 20 years back, then we have only limited number of drugs, but now we have more options available in market and national program. You can see here on NRTI or nuclear transcriptase inhibitors, and you can see here we have like tenofovir, disoxyfumarate, and this is PDF, and then ABC or abacavir, tridovudine, lamivudine, emtricitabine, and adenosine. So there are different kind of drugs which are approved by both FDA and Indian government, NACO, and these are available under national program. And you can see here some more drugs like tenofovir, penamide, and this is a kind of better drug. It's a substitute of TDR, and it doesn't have any renal toxicity. As we know that TDF have some kind of renal toxicity, people are using more this in the persons who are having any underlying genotoxicity. And then we have other drugs which are in the clinical trial. So these drugs are also going to be available in the future. Coming to the non-nucleotide reverse transcriptase inhibitors or NNRTI, and you can see here we have FDA or NACO-approved drugs here which are available under national program. We have two drugs in the national program, neverapine and efavirenz. So these two drugs are available in the national program, but we have some more drugs which are available internationally. And these may be available shortly in our country also. And there are some drugs like doravirine in the phase 3 trial in US and may available in India shortly. Coming to integrase inhibitors. So these are also very important drugs, and these are now we using as a first line drug also in our country and abroad. But in the national program, we don't have as a first line drug. And we are using these drugs in sometime in multidegradation HIV. Also, when patient is having multidegradation, so we have option of prelactin and we have altopravir and elvipravir. So there are different kind of integrase inhibitors, and we have in India too reltipravir and toltipravir, and toltipravir available under national program for limited use. And we have some other drugs like which are under clinical trials and may be available in future in our country. So coming to the protease inhibitors. So you can see here that we have lopinavir, we have atyanavir, we have ritonavir, indinavir, and sequinavir, and some more drugs like lenferavir. So these are protease inhibitors, and we are using these under national program as a second line drug. So, but in other countries, and we use them as a first line drug if patient is having kind of HIV depression or multiple mutations. So we can use them as a first line drug also. But in national program, we are using them as a second line, or when first line regimen is getting failed, then we use these drugs. And similarly, we have CCR5 inhibitors, and this is another class of drug. And we have in India like Maravira, which is available in our country, and we use in patients who have multidegradation, AIIMS, and other drugs which are we have some more drugs under trials and maybe available in the near future. So how to construct the regimen? So this is very important because we have limited drugs regimen in our country in the national program. These antiviral drugs are very costly, and once you start antiviral drugs, it goes lifelong. So it is very important to tell to the patient before starting antiviral therapy. So we have to do adherence counseling to the patient in detail and tell about regimen. We have to tell about the side effect of drugs. We have to tell about the importance of adherence of the drug. Because if patient is not taking drug on daily basis or they are skipping the dosage, it can lead to the treatment failure or it can lead to the new mutation, and that will cause the multiple HIV and AIDS. So one has to be very careful and tell them that they have to take these drugs on daily on particular time, which is mentioned by doctor in the RT center, and they have to come back every month, and we generally give them for 1 month treatment and then call them back and do physical examination and give them back for 1 month. So here are some, you can see that we have certain classes of drugs or regimen. So we generally start with the 2 NRTI plus 1 NNRTI, or we start with 2 NRTI or 1 protease inhibitor. So there are like classes. You can see here, I more emphasize on the Indian NACO or this WHO guideline. So we have kind of NACO have tenofovir with lamivudine, and we have efavirenz. So this is very common regimen used by in our country, and this is available as a single pill nowadays, and one can take the single pill after dinner or before dinner. So this is generally we give every day, once during night time, and this is available free of cost as a single tablet form. So what are the other regimen available under NACO or National Aid Control Organization? We have I already told you about tenofovir, lamivudine, efavirenz, and then we have other regimen like abacavir, lamivudine, efavirenz, and we have tenofovir, lamivudine, and leponavir retinol combination, and we give this combination in first line after for all women with a single dose neoepinephrine in the past pregnancy, and all confirmed HIV-2 or HIV-1 negative. So this is the kind of special regimen we use in the particular situation. And then we have combination of tirovidine, lamivudine, and nevirapine. And here we put all patients who are on either of these first line regimen, limited or initiated earlier in the program, need to be continued on the same regimen unless failed. So if anybody is earlier, like before 2017, then there was no combination available with tenofovir. So then if patient is there on tirovidine, lamivudine, nevirapine, or efavirenz combination, so we just continue them on the same regimen, and as soon as they are getting failed, we switch on combination of tenofovir, lamivudine. So these are the most important slides for your point of view. If somebody asks you to what are the treatment regimen for needs or first line antiviral drugs, then you have to mention these kind of ART regimen. So coming to the other newer approaches which are available here, so which are available like we have long acting antiviral drugs. And then we have growing therapy like alticlavir and lamivudine. And then we have some PI-based regimen with NRPI. And then we have some immunosuppressant agents also, which are going to be available in the future. So there are different kind of newer approaches are also available, which are going to approaches, or some are available in other countries, but not exactly in India. So here you see that some drugs are available as intramuscular long-acting maintenance ART therapy also, and this is kind of a trial is going on, and it is a multi-center trial, and this is phase 2B study, open label, and here they have used 30 milligram per roller QD and with combination of or lamivudine. And they are doing this study with the combination with the other combination of other drugs. We are just looking for it. So there are some dual therapy regimens are also available. As we discussed, the most powerful regime is three drugs, minimum three drugs regimen. So there are some regimen people are using as a dual therapy regimen also, and there's a drug called relfegravir and leronavir kind of leronavir combination is a kind of boosting drug, or leronavir and leronavir combination with lamivudine. So they are using this combination also as a boosting drug, and they are found it is also one of the treatment options. So other emerging investigational agents, I think it is not very important that you are relating to under going to leave this. And coming to the opportunity. So what is the prophylaxis of treatment for the opportunistic infection? So we commonly see following opportunistic infection in HIV and AIDS, we most commonly see PCP or pneumocystis pneumonia, tuberculosis, which is very common in our country. Then we have MAC, we have oral or esophageal candidiasis, histoplasmosis, cryptococcosis, and we have toxoplasmosis. So there is a range of opportunistic infection we can get in the patient who are suffering with HIV and AIDS. So commonly we see toxoplasmosis and see the compound is less than 100, and treatment is combination of sulfotrax and if we give one double dose times 1 day. And then we have basically another common infection, another common infection. And this is mostly we see in the patient that it is profound less than 200. And here also we take combination of antihistamine and sulfur drugs. And we say also we take one tablet double dose per day. Then we have MAC infection is also seen in the patient who has CD4 count less than 50, and the treatment protocol is azithromycin once per day. And tuberculosis also nowadays we're treating as per guideline, and we are giving them AIIMS for 6 months, one more week. And before starting that, we do screening of we do fingerprint test and we take the contact history from the patient if they have and contact history with that will be positive patient. Coming to the oral and esophageal candidiasis, so there is not much recommendation is available from NACO, and if for treatment point of view, we give patient antifungal drugs like fluconazole, and we give them 200 to 400 milligram OD, and once we keep on observing the patient consultation, and minimum is about 4 to 8 weeks. And then histoplasmosis is more commonly seen in the patient who have CD4 count less than 150, and we treat them with the itraconazole 400 milligram OD. And one more important cryptococcal infection, it's more common seen in the patient who have CD4 count less than 100, and also in the area which are having high prevalence area with infection. And we treat them with fluconazole 400 milligram OD. So this I have already told you how to give this isolated function therapy. We give them 100 milligram OD for 6 months in our country. And then failure and monitoring is also very important. So in our country, as a NACO guideline, what is the definition? We say patient in the failure. So we monitor patient is a clinical failure, or patient is an immunological failure, or patient is an biological failure. So this is very important to understand when we see patient is in clinical failure on antiviral therapy. So some patient is taking antiviral therapy and if they get getting failures. So what are the symptoms we see? We see new or recurrent clinical events or new onset of chest infection or any other persistent infection which I discussed in the previous slide. So here, when after starting the 6 months of antiviral therapy, so we say patient is not responding to antiviral therapy and there is a kind of clinical failure. And what about immunological failure? So as per NACO guideline, if patient is having CD4 count fall, to the pre-treatment, like if patient, any patient who is having pre-treatment CD4 count 100, and after 6 months of treatment, they have CD4 count, that means they are getting immunological failure. Or patient is having 50% from on the treatment peak value, or there is a persistent CD4 levels below 100 cells per millimeter. So there are three kind of immunological failure that is very important to understand. All in CD4 count with a pre-treatment 50% fall from on treatment peak value and persistent CD4 levels below 100 cells per millimeter. So here another thing is available, that is viral load or RNA viral load for HIV, and we also measure the biological failure, and that is available in the national program and the NACO. And we say when viral load is more than 1,000 copies per ml after at least 6 months of antiviral therapy, then we say patient is having kind of biological failure. So there have to be either a one or all kind of failure. Then we say patient is under ART failure, and we can just do the HIV resistant testing if it is available, and we have to treat or we have to start new regimen as per the resistant testing reports. So what are the recommendation of HIV resistant testing? So as per international guideline, Department of Human and Health Services, we say that who should be tested for HIV resistant testing. The patient with the viral failure and HIV-1 RNA with HIV-1 RNA levels more than 1,000 copies per ml may be considered for patient with 500 to 100 copies per ml. So we have seen if you are applying to do HIV resistant testing, then it's better you have high level of viral RNA levels, and we generally do HIV RNA levels. We do HIV integration testing when RNA levels are more than 1,000 per ml. And when to be tested? While on failing regimen or 4 weeks from starting the treatment. So when patient is having, like on ART, if they are having clinical, virological or immunological failure, then one have to be tested for HIV resistance. And what are the types of testing? So there are different type of testing. In India, we do genotyping, and we have kind of in-house facility, and there is a kits also available for doing sequencing or genotyping. And then other consideration like prior treatment history should be okay. So there is a guideline or recommendation from different societies, and we, based on those guidelines, we do HIV resistant testing. And I would like to tell here that is a costly test. So as a national program, we don't have facility of HIV resistant testing for now, but maybe it will be available in the future because it's a very important test. And now many patients who are getting developed mutation or HIV resistant failure, we are able to diagnose at early stage, and they are landing as a multi-resistant HIV infection. So coming to the pre-exposure prophylaxis, so this is also very important regimen nowadays and very important thing. And generally, we give daily oral fixed dose combination, and indications are indication for the pre-exposure prophylaxis in the patient or persons who are sexually active or dead, MSM men who have sex with men, or adult heterosexually active men and women at the substantial risk, and adult injection drug users, and high discordant couples, so HIV discordant couples. So these are some indication where we start pre-exposure prophylaxis and these kind of new regimen by different societies in USA and recently in the process in NACO also. So we have combination of tenofovir 300 milligram and FPC 200 milligram daily and we give 3 months regimen once, and then we call them back and we do HIV testing. If patient is negative, then we give them again for 3 months regimen. So there are different kind of studies have been done for pre-exposure prophylaxis using antiviral to prevent HIV infection, and the most common is partners PrEP or pre-exposure prophylaxis regimen, and this is kind of combination of tenofovir and FTC in one arm, and another arm is tenofovir only. And they have found that there is a significant improvement in the patient who are having combination of the drug. Another drugs is available in the microbiocide gel form, and this is kind of tenofovir was in a gel, and this is done. There are some trials done, and if it's found, then it is effective about 39 to 54%, and it also has been reduction in the HIV acquisition among the women and pre and post exposure prophylaxis. Coming to the post-exposure prophylaxis, and this we use in the patient who have needle-stick injury, in the patient who are having high suspicion of HIV infection or who are HIV positive. So somebody, for example, if some resident or nursing staff or technician is taking blood sample in the ward and they get the needle-stick injury, and if there is a high suspicion of HIV infection in the patient or is a known HIV positive, then one have to start antiviral therapy, and this is called post-exposure prophylaxis, and we start this within 2 to 72 hours of exposure for 4 weeks, and this is kind of 3-drug regimen preferred over the 2-drug. And we have, like in India, NACO have presently combination of 2 NRTI and 1 NRTI, like we have. It's those combination of tenofovir, lamivudine, and efavirenz. We give OD we give once per day for 4 weeks. And if patient is having underlying history of resistance, then we give combination of protease inhibitor, base regimen if failure is suspect. So this is very important to understand. You might get the short note on the post-exposure prophylaxis. So you just this is very important to do baseline HIV testing in all the recipients or the post-exposure prophylaxis. Then we'll do repeat after 2 weeks and 6 weeks, and then after 12 weeks. And coming to the this antiviral drugs during pregnancy. So in the mother, antiviral drugs during pregnancy and breastfeeding, and the first trimester, we now start combination of tenofovir, lamivudine, and efavirenz combination. The 3 drugs combination are available in the single pill, and we give 1 pill every day, and this is in the patient who are positive with the HIV positive and having pregnancy. So we give antiviral therapy in all pregnant women irrespective of CD4 count. And then NAGO have suggested that exclusive breastfeeding in first 6 months, then gradual introduction of complementary fluid maybe suggested in these females, and infant prophylaxis is exposed 6 weeks. We give 6 weeks neurapine syrup to the infant. There are some other regimens are also available. So as per WHO guideline, we give tenofovir and neurapine, lamivudine, and efavirenz. So we give 3 dose combination as a single pill. And if mother is already on ARD, we continue with the same regimen, and if breastfeeding means we should replacement, as I displayed in the previous slide. And if neonatal prophylaxis, then we give developing neurapine for 6 weeks, high risk of developing neurapine for 2 weeks, or for 12 weeks in the high risk group, or neurapine for 12 weeks. So coming to the HIV vaccine, we have a lot of trials going on the vaccine, on HIV vaccine, but still we don't have vaccine in market. So hopefully in the future we will have some vaccine in the market for the therapeutic point of view or preventive point of view. So we are just waiting for vaccine, and we have different kind of trial like monoclonal antibodies. We are CO1 trial, and then we have activator of transcription protein vaccine. So there are several trials are going on. And now I would like to stop here. And if you have any question, then I can have question. Like to answer that question. Thank you.
Classes नहीं
Yeah, do you have any question? Can you hear me? Dr. Shawan, are you there, Dr. Shawan?
Yes, sir, I'm here, sir.
Yeah. Any question? Yeah, want to ask any question?
Yes,
Any
sir.
question from a student? They can type in the chat box. You can
Any
answer.
questions?
Otherwise, we can take the
Yes, I'm.
attendance.
Okay, sir. I will take.
So I'm just logging out. Okay, I have one more.
Okay, sir. Okay, sir. Thank you so much, sir.
Yes, please. Okay.
Okay.
Thank you. Is that okay? Thank you.
Attendance 18.
अटेंडेंस लगाओ छोड़ो नहीं लगाई मैडम ने बोलो आप इस पे
यार जी ठीक है
हाँ सर
यार जी लॉग आउट करो
यस सर यस सर यस सर ओके सर ओके
आवाज वाज दिस साउंड वाज ओके
हाँ हाँ सर ठीक है सर ओके